Thank you. So I'm going to talk to you about sickle, and I'm going to start by trying to sort of set the framework so everyone's all on the same page on what sickle's about. Then to talk about the impact of sickle. It's a multi-system disorder which has really quite devastating impact, as you all know. The current treatment landscape, unfortunately, that part of the talk is going to be relatively brief, because there are very few treatment options for sickle cell patients, and even fewer now after fairly recent developments. But I will try and sort of raise our optimism levels with some novel therapies that are going through clinical trials, because we need something for sickle. Obviously, Tom, back there, it will talk to us about gene editing, as Dr. Lutmani's already sort of alluded to, and Professor De La Fuente, who I hope will be here, will also give us a talk about stem cell transplantation in sickle, which are both really exciting options for curing patients with sickle cell disease. Unfortunately, I get the less attractive and quite boring bit, but I'll try my best. So the pathology of the disease. Before we do that, I just want to talk to you a bit about the epidemiology. Sickle cell is the most rapidly growing monogenetic disorder worldwide. In the UK, affects about 70, depends on who you speak to actually, between about 17, 18, sometimes 19,000 people, the vast majority of which live in London. I'm always devastated by clinicians, healthcare professionals who work in London that don't know what sickle cell disease is, or have a very limited understanding of the disorder. You've got no excuse in this part of the world. And we're very fortunate in the UK. So Kofi sort of alluded to it. In sub-Saharan Africa, the mortality for sickle cell disease is about 70%. 70% of children will not live beyond their 5th year. That's really quite sobering. So this kind of says what I've already said. So for time reasons, I will not go through it again. Dr. Lutmani's talked about globin chains, in adult hemoglobin, 2 alpha-2 beta chains. In sickle, there's a mutation in that beta chain which changes the shape and the function of that chain, which has an overarching effect on the protein and a subsequent effect on the way in which the red cell functions. Though we seem to fixate on the SS, the hemoglobin SS, the sickle cell anemia patients, though that contributes, I'm always slightly hesitant about this slide, because with the use of the word severe for SS, suggesting that the SC isn't severe, I always struggle with, and our patients get very angry when they see things like that, because the SC patients unfortunately have a very raw deal. There are very few options for them. And some of them do have very severe disease. There are some weird, less common combinations that Asad's already alluded to that contribute about 5% of the sickle cell disease patients, or sickle cell disorder patients, depending on what you're referring to. This slide is complicated, but what I want to do is just try and explain 2 very basic things. So in low oxygen partial pressure, so when the blood returns, when the hemoglobin has released its oxygen to the tissue and is returning back through the venous system to the heart and then to the lungs, the oxygen partial pressure falls, and as a consequence, the red cell the hemoglobin changes its shape. And that shape change, that conformational change in that hemoglobin, causes 2 things. This is why it sort of splits off in 2 directions. On the sickling side, the red cell becomes deformed. It then starts to become more in that shape that it adopts, which doesn't have that flexibility that the normal red cell has. It becomes very fragile. It also becomes increasingly sticky. So it has these proteins, the adhesion proteins, which make it stick to other cells. including the inner layer of the blood vessel, and that causes a vasoocclusion. That's this part of the program. This other side, just going down the left, is because these cells are so fragile, as they try to maneuver through the small blood vessels, they break down and they release their content, which includes free heme. And that's quite important for the part of one of the treatment modalities, which I'm going to talk to you about, the complement inhibitors, which we'll come to right at the end, which try to short-circuit this process, where this idea of switching off the activation of this very inflammatory process to try and ameliorate the disease. As I tried to allude to at the beginning, the impact of sickle is devastating. We all know about pain, and depending on what you read, it's about 70 to 90%, even higher in some publications, of all hospital admissions, all unpredicted, unscheduled hospital admissions are due to pain. And pain is an important feature of the disorder, but it's only the tip of the iceberg. If you're sickling in your bones, you're sickling elsewhere. Your lungs, anything that has a blood supply can be affected to sickle, which is effectively everything. So you need to be mindful of all of that, because some of our patients say, oh, I don't have pain, so why do I need treatment? Why do I need hydroxycarbamide? Because you sickle. And though you may not be overtly manifesting your problems with painful crises, the effect on the eyes, the heart, the liver, the kidneys, all of that, with time, as you age, will start to cause deterioration in your condition. And this slide tries to illustrate that with even greater sort of robustness. This is a life-shortening disorder, unfortunately. In childhood, the major cause of death is stroke, and in adulthood, significant morbidity associated with an acute chest syndrome, which is a combination of sort of sickling within the blood supply that supplies the lung, and what we call an acute lung injury, where the blood vessels start to leach fluid, making the gas exchange, so the oxygen going to the tissues, going to the blood, that transfer is impaired. And as a consequence, you get an amplification of the sickling process. And this ultimately leads to death. So that's why in adults, we get very fixated about knowing what patients' oxygen saturations are. Because that's an early indication that a patient may be developing an acute chest syndrome. What I didn't want to do is focus purely on the physical. Sickle has a really strong psychological impact. I was really quite taken by a couple of things. So this one over here, that about 40, this is a SWAY, I think you were involved with, Kofi, the SWAY survey that looked at about 2,000 patients worldwide and showed that almost half of them showed signs of depression. What is probably even worse is that I saw the report. So basically, this is an indication of a quality of life index. So how people feel day to day. And in adults with sickle, they consider they score their quality of life lower than those who have an active cancer on chemotherapy. I found that really quite horrifying. As patients start to pick up complications of disease, their mortality starts to drift down really quite dramatically. And once that starts to happen, then their ability to utilize certain medications that are effective reduces, patients develop drug intolerances, we can't optimize treatments, and it's really just a sort of a spiral to, unfortunately, inevitable death. So what we need to do is to be able to halt this process so that patients don't start to develop organ complications. Because when that starts to happen, then there's a certain inevitability of everything. So, the very short bit of the presentation, the current therapies. So this slide is really, it's a very busy slide, but the whole point of this slide is to show that a lot of what we do doesn't have any evidence base. So we give patients fluids, we think it helps. There's no evidence to support that. It's a whole series of trials here, all of which don't agree in the premise that hyperhydration, giving patients supplementary oxygen, or the use of opioid analgesia, instinctively these things are helpful. And I certainly wouldn't want our patients to be rolling around in agony, but there is no evidence that any of these are standard of care, that any of these really have any impact on disease. And this kind of illustrates the problem. Patients with sickle cell disease live at least 20 to 30 years, don't live as long, oh God, I'm struggling with this one. Patients with sickle cell disease live 20 to 30 years less than their ethnically matched peers. And we applaud ourselves because we've managed to get the numbers up from where we were sort of 30, 40 years ago. But that's really quite sad that we haven't managed to improve the quality of outcomes, the care that we develop for our patients. There have been some things that have made difference, and they're really quite limited interventions. Having registry, so we know how many, a lot of this is American data, but we've done the same in the UK. Having registry, so we know how many patients we have, and we can allocate resource accordingly. But there have been some trials that have made a difference. And the use of penicillin prophylaxis, that has significantly increased mortality and morbidity within the UK, particularly within children. These are hydroxycarbamide, which we'll talk about in a minute, and transfusions. These are the only real interventions that have made a significant difference to the outcomes of patients with sickle cell, but a very limited difference. So hydroxycarbamide. Another very busy slide. We talked about, you all know about fetal hemoglobin now. Dr. Lukmani very eloquently explained it all to you. So fetal hemoglobin is a non-sickling hemoglobin. It doesn't have a beta globin chain, and we know that the beta globin chain is a defective component that is affected in sickle. So if you can increase the amount of fetal hemoglobin, you can reduce the effect of sickle cell. I talked about proteins and making the cell sticky. These adhesion proteins. And this is where crizanlizumab, a dirty word now, but this is what crizanlizumab focused on, the selectins, and reducing the adhesion between different cells and the inner lining of the vascular wall. And it also increases nitric oxide. Nitric oxide is important for maintaining the vascular, so the blood vessels can relax and contract as they should. Nitric oxide is vital to that process. However, when the red cell breaks down, it releases free hemoglobin, free heme. And when that happens, one of the things that scavenges that free heme, which is very toxic, is nitric oxide. So sickle cell patients are inherently nitric oxide deplete. So their blood vessels don't move that well. And they become very stiff, and that causes a whole heap of other clinical problems. So hydroxycarbamide. So this is the only drug that's licensed in the UK for sickle cell disease. And we've been using it for over almost 30 years now. And we've got good data of its efficacy. It reduces painful crises, reduces the number of transfusions patients receive, it reduces all complications of disease. It does have its problems. It does have side effects. We'll talk about those in a minute. There is a big problem with non-adherence, and I think, so we're trying to do some work to try and understand why sickle cell patients don't want to take hydroxycarbamide, particularly given it's the only real option for most of our patients. And there's a lot of misconception, and I think that's what feeds a lot of all of this. This slide tries to illustrate what what hydroxycarbamide does in sickle. So this is a sickle cell patient. This is a blood film of a sickle cell patient. You can see a sickle cell there. You can see very small cells. The cells that are larger don't have much in the way of hemoglobin in them. Patients 8 weeks into taking hydroxycarbamide, their hemoglobin hasn't changed a great deal, but the MCV, the size of the cell, has increased because the cells are better hydrated. And when they're better hydrated and they're bigger, they're often better hemoglobinized as well. So they can carry more oxygen around. 20 weeks in, the hemoglobin's increasing. The MCV, the cell size, is also continuing to increase. The white cell count, and the importance of the white cell count, obviously we need to be mindful of the white cell count going down too low. But the white cells contribute to the formation of this vaso-occlusive process. Because because of the stickiness of the red cell, they contribute to that process. If the white cell count goes down, then that can sometimes ameliorate the problem as well. One thing I also wanted to highlight is there's a stepwise increase in the dose of hydroxycarbamide here. Sometimes you have to go back. That's fine. But you should aim to get your patient up to a good maximum tolerated dose. And normally we say 30, 35 milligrams per kilogram per day. Some patients don't get to that, but we should make an effort to get them as high as they can so that the drug has its optimal effect. And by 22 months, so they're well in there, they're almost 2 years in, the hemoglobin is approaching normal, come up by 3 grams or 30 grams. MCV is high, all these sorts of good things are happening to the red cells, and the patient, I'm sure, is starting to feel benefit. So generally, a well-tolerated drug. I know some of our patients would argue with that point. There are some side effects, and there's some early side effects. Patients can get gut irritation. But if you give the dose at night, that often helps. Oops. You can get sort of transient reduction in blood counts, and they need to be monitored. And there's most trust, and there's a sort of a general national sort of schema for how we approach this. There is no, and this is one of the big misconceptions, there's no association with leukemia, with sickle. I think that the early data looked at rodents getting massive doses of hydroxycarbamide, and there was a signal that possibly there was an association with the onset of leukemia, and that unfortunately has stuck. So a lot of our patients worry that, one, because of the association with this drug being used in modifying patients who are having treatment for cancer, and because of this data, a lot of our patients think that they're either going to get cancer, or you think they have got cancer, and that's why you're giving it to them. Massive misconceptions that we need to work. Cosmetic things. Hair. Black women love hair. So I can understand why. I haven't got any, so I don't have any problem with it. But if sort of thinning of hair can sometimes be a problem. Nail changes, and these are important to patients, so we need to be, I'm being slightly jovial about it, but it's important to patients, so you need to be sort of sympathetic to the cosmetic problems. But you should also always try and reapproach these issues if you do stop, because there are very limited options here. Just need to speed up. So I'm just going to rush through this relatively quickly. So you do some baseline tests to understand where you are with the counts. And then you would increase dose from around about 15 milligrams per kilogram and increase them stepwise over the course of months to either a maximum tolerated dose or until you get significant clinical benefit. You would monitor them with a blood test at 2 weeks after they start, or once they've had a change of dose, and or every 3 months when you'd reissue a prescription to them. So the signs of toxicity are when they have any clinical manifestations of cytopenia, marrow suppression, or when the blood counts are below these targets. We rarely see significant renal impairment, though those patients who have a pre-existing renal problem, it can sometimes be really difficult. And this is what I sort of alluded to earlier, is when patients start to develop these complications, optimizing dose like chelating agents or hydroxycarbamide it becomes extremely difficult at the time when they most need it. So blood transfusion. So I'm not going to the audience knows all about blood transfusions, but I think the only thing that we need to be really mindful here is that, unfortunately, this treatment option does come with risk and complication. And in the vast majority, so UK blood is generally safe, but the problem is the donor group is ethnically different from the recipients. So the risk of alloantibody generation is significantly increased. And that's something that we need to be really careful about, because blood transfusion, and as I'll show you in another slide, is one of the gold standard of treatment options. And if you remove that option by transfusing people unnecessarily, then you start to run into real problems when they really need it. So Fred Peel and colleagues did a study looking retrospectively, a cohort study looking retrospectively at almost 10,000 patients over 10 years within the UK with sickle cell. What they did is they grouped the patients, quite interestingly, into those patients who have had repeated. So if a patient had more than 4 crises in a year, they were put into the, I haven't got my glass on, it always helps, into the cohort group. Those patients were on transfusions, so they received regular transfusions within the transfusion group. Those patients, despite being on transfusions, still continued to have crises, were put in this group, and the rest of them sat in as others. So these patients who are having crises despite being on regular transfusions, I would consider those the most severe sickle cases. If you look at the group that have regular crises and compare them with the group that are on transfusions, what it clearly shows is transfusions does have benefit. Almost all of these matrix, almost every single one of them, is a significant reduction in incidence of the complications. But interestingly, looking at these two groups, so again, looking at the crisis groups, so the patients who are having regular crisis but not on any definitive, or who are not on any transfusion program, comparing those with the patients despite being on a transfusion program, continue to have crisis, the numbers are almost identical. What this tells me is there's a cohort of patients, despite being on regular transfusions, continue to have severe complications. It's really quite disturbing. And what this says, that we need a treatment option for these patients. Transfusions isn't enough. This was one of the other sort of components of the study, and I'll run through this really quickly. Basically, what this says is even those patients that are in the other group, so don't have regular crisis, not on a transfusion program, they still have poor outcomes. What this says to me, there's no such good as a good patient with sickle. You hear about people say, oh, they got good sickle, they don't have regular crisis. People still die early from sickle cell. Everyone needs some sort of intervention. And unfortunately, we don't have that to offer them. I told you it was really depressing. Okay, novel therapies. So this is a whole list of drugs that were initially developed for other treatments, for other disorders. And because of their mechanism of action, it was considered they may be useful in sickle. So we have 2 drugs here that unfortunately are no longer available to us on the market. Well, crizanlizumab is available in the States still. So if your patient wants to go to the United States and pay for their treatment, then they'll get crizanlizumab. But unfortunately, for the vast majority of our patients, it's not an option. Voxelotor is not available to anyone anymore. And then, so L-glutamine, it's used in the States, it's got limited benefit, and apparently it tastes disgusting. So, unfortunately, we're in a situation in the UK where we have very little available to our treatments available to our patients. The 2 things, I still struggle to understand, I still try to fathom that last year, we had 2 drugs introduced for sickle, a time for great celebration, and both drugs were withdrawn. So we'll end on a bit of optimism. So the clinical trial options, so Dr. Lukmani alluded to this before. He talked about pyruvate kinase activators in the context of thalassemia. They're being trialed in sickle as well with good effect. Complement inhibitors and hemoglobin modifiers, and haploidentical transplants, which Professor De La Fuente will talk about. He will talk about. Those are where we actively have clinical trials for at the moment. So mitapivat. So this is a small molecule pyruvate kinase activator, first in class, and basically what it does in sickle, because I'm very short of time, what it does two things. So what it does is it increases the energy for the red cell. So the pyruvate kinase is an enzyme which sits at the bottom of the glycolytic pathway. The glycolytic pathway is responsible for generating energy within the red cell, within cells actually, including the red cell. So if you can increase the activity of that process, you can increase the ATP, the energy of the cell, and that energy will help overcome some of the challenges sickle create. What it also does is it reduces a particular protein, 2,3-DPG. Who cares what it's called? But it reduces that protein, and that protein is essential for the release of oxygen, or determining how quickly the hemoglobin releases its oxygen to tissue. Now, for those of you who are paying attention near the beginning, it's a deoxygenated hemoglobin that polymerizes and leads to a cascade event that causes the complications of sickle, the vaso-occlusion and the hemolysis. So if you can stop that release of oxygen, or you can limit the release of oxygen, then you can ameliorate the disease. So this drug has been trialed. We were involved in some of the more recent trials, a lot of the trials actually, and it's working really quite effectively with a lot of our patients. So the estimate was a phase 2 study, and not to bore you with too much detail, reduces sickling, increases hemoglobin, and reduces hemolysis. So all very good things, and very few side effects. A tablet that's taken, and so it's an option that's really quite accessible, potentially quite accessible to a lot of our patients. Rise Up, so this is a phase 2 clinical trial, to a phase 2/3 clinical trial for the same drug, and this is relatively new. This is this study was just released, 2 weeks ago. And what it showed is that about half of the patients showed a significant rise, over 10 grams increase in hemoglobin, some significantly higher, some up to 4 grams increase. Though the study wasn't powered to assess the incidence of vaso-occlusion, those patients that received the lower dose of mitapivat showed up to 50% reduction in vaso-occlusive crises. Those patients who received the higher dose, 100 milligram dose, they showed up to 70% reduction in the incidence of vaso-occlusion, as well as a significant increase in hemoglobin. And we need to be mindful of living with, as you alluded to, Kofi, living with a hemoglobin as low as a lot of our patients does have its impact on your quality of life. So getting that hemoglobin up, as well as reducing the incidence of crisis, is really quite important. We're nearly there. So I mentioned complement inhibitors, and basically the alternative pathway complement system is activated by free hemoglobin. So as you start to break down your red cells, when you're sickling, you release free heme, and that free heme activates the alternative pathway. And that causes what was called a hyperinflammatory process. And it's a vicious cycle. As you start to activate the alternative pathway, you then have more and more crises. You have more and more, hemolysis, and so on and so on. So if you can stop that process then there is a hope that that would actually ameliorate disease. This drug has been trialed in another hemolytic disorder called PNH, and has been quite effective in that disorder. I'll not say any more about that, for reasons that some of you will know. But we were, and I know that at London Northwest, you had some of the trial open for crosswalk, and crosswalk A and crosswalk C, so the acute trials. So when patients come acutely with a painful crisis, they get a single dose of crovolumab, or when they came in, so those patients that had regular infusions of the drug to prevent or limit recurrent, or sort of a prophylactic measure effectively. We shall see. It's the jury's out in this context. Because our patients are chronically immunosuppressed for a variety of reasons, the question is how appropriate is you to further immunosuppress them. But I do think there's some value here. So to try to limit an acute crisis, limit the severity and the duration of acute crisis, I do think there's some benefit of using these drugs. So my final thoughts, this is my last slide. The final thought, so sickle cell is a devastating, life-limiting disorder that we certainly haven't done enough about to understand and develop good treatments for. As you can see, we have hydroxycarbamide and we have transfusions. So we have an extremely limited armament to challenge this disorder. New therapies, new very promising therapies are coming down the line, so I'm very optimistic in that regard. And Dr. Blair and Professor De La Fuente will give, I'm sure, very excellent presentations about curative options for patients with sickle cell. And that's me.
Thank you.
Don't mind clapping. Thank you.
Well done, Stephen, for racing through a complex topic. Just as Asad managed to put thalassemia in the perspective as well. Do we have any quick questions?
No.
Hi, thank you for your presentation. I just wanted to pick up on your quote that you said everyone needs some sort of intervention. And I just really wanted your opinion on a patient that has a naturally high F% but hasn't got HPFH. And the consultants I work for have never started hydroxy treatment for this patient. And I can't understand why, if you can answer that.
If I'm honest, I'm not sure I can. I think what you would want, in those situations, you would want to make a decision based on the individual. You need to know how high the F is, what other complications they've had. I think in saying all of that, I think we wait too long to treat patients with sickle. I find that I always really quite disturbed by the fact that we stratify patients. We say you've got severe sickle because you've had a stroke, because you've had multiple acute chest syndromes. It's too late then. What you want to do is you want to identify those patients who are high risk early, treat them early so they don't have a stroke or they don't end up on ITU multiple times. All that being said, I think on that specific case, you'll need to look at the parameters and make a decision. We do have national guidance in relation to the so-called severe HBSS and the HBS beta naughts. So they should all be offered hydroxycarbamide. So if that's what this patient has, then that, regardless of the F, I think, we should offer them something. Because you can always push the F up higher and limit complications even better.
Yeah, that's my opinion, but I'm the nurse with little...
So with the Hammersmith, we have the utmost respect for our nurses. So their opinions are taken into consideration at every juncture. I say that because they're both sitting here. I'm joking.
We've got one here. Yeah.
Hello.
Hello. Oh,
Hello.
Hi. I've just two questions, if that's all right.
okay.
Do sickle patients develop a tolerance to hydroxycarbamide? Does the effect wear off over time?
So the simple answer is that. So it's a very difficult question to answer. So I guess to a certain extent, what we do badly, what the Americans, I've never said this, what the Americans do better than we do is that they get the patient up to a maximum tolerated dose quickly. They accelerate them really quickly up to the maximum tolerated, and they leave them there. We give our patients 1 gram of hydroxycarbamide, and they feel a bit better, and we stop. And I think that's part of the problem. I think what we need to do is try and accelerate our patients up until they get to their 30, 35 milligrams per kilogram per day, or they start to develop cytopenias, which is normally the big issue. But we don't do that. And I wonder whether that's why we start to describe it as tolerance. Also, when you start to see tolerance, you need to check compliance. Because a lot of patients don't take it, if I'm honest.
Yeah.
It's a prophylactic, it's a preventative measure. So often patients you don't see the benefit day to day, just when you start to have problems. So, and as I said, there's a lot of misconceptions that it does this to you and does that to you. So people are really quite reluctant about taking the drug. So a simple answer about whether patients can develop tolerance. It was on one of my slides, I know, but I don't really. I think you need to take that, as I said, again, take that in the round. It's difficult to say.
I think we'll take one question from here, and then we'll need to have a break. Hopefully, there'll be opportunity at the end, but other speakers have been waiting. So the break is actually going to be like, grab something and come back. 2 minutes, that's it. So one final question, and then we'll...
Thanks. Firstly, just to comment on the question about the high hemoglobin F level. I think I agree that it would be reasonable to trial hydroxycarbamide. We have a few patients that I'm aware of under our care that have benefited, and pushing their F up further is helpful. I mean, a lot of patients from the Middle East in particular have high endogenous F levels and still benefit further from hydroxycarbamide, so I think that's not a reason to withhold it from those patients. Stephen, I wanted to just ask you, you know the data you presented from Fred Peel's study?
Yeah.
I wonder if you could just comment on the fact that I noticed that in the transfused arm, or transfused group, versus the ones who were having crises, there was a much higher risk of stroke in the transfused group. I was wondering if you could explain the reason
I
for
can't.
that.
It's not really my data, so that's the data they want to know. He didn't touch on that in the publication. I can share it with you.
I think it was
But
quite
doesn't
significant. It
touch
was
on
about between from 5 to about 19% in the transfused arm, which is surprising considering we use transfusions as a
prevention for stroke.
prevention for stroke.
So all I would suggest is that possibly because those patients who, by definition, who are on transfusions are those that are the higher risk. So as we sort of alluded to, we wait until someone has a stroke, and it may be that because if you look at the graphs that relate to stroke and sickle, it's sort of a bimodal thing. It goes up and down, and I wonder whether some of those patients, they've had previous strokes, and that's maybe why they're on a transfusion program. And as a consequence, they develop moya or sort of a neurovascular disease, which puts them at high risk of developing further stroke and sort of hemorrhagic stroke or something else. That would be my only sort of summation of the data, that it's because those patients are higher risk, that's why they're developing stroke.